guys. Good morning and welcome. It's 9:02, so I'm going to go ahead and get started. I am recording this so that I can go ahead and post it to the shell, or to your email actually, so that you guys can access it again, or those of the students who are not here can watch it later. I want to start off and just see if there's any questions that you guys have, questions or concerns that you might have.
I have a question.
Everyone's feeling, oh wait,
Can you hear me?
okay, now I can hear you, yes.
Okay. I saw that like normally we have pre-lecture like quizzes and stuff due, but
Yes.
for the content this week is none of that due?
Correct, you don't have that due this week.
Okay, thank you.
You're welcome. Any other questions, concerns before we get started? No? Okay. So did anyone get their book and get access online? Okay, Cami did. Perfect. Okay. Cool. If there's any issues, please let me know and I'm happy to work through them with you. So I sent you all an email attached to the Zoom link and it had quite a bit of documents in there. So it had all of the PowerPoints as well as the worksheets. Now the worksheets are a tool for you to use. Definitely they don't have to be used. If you find them useful, great. I have one for every chapter that we are going to cover. If you don't find them useful, please don't use them. But they are posted in your shell with each week. So on Wednesday, when you open up your shell, you should be able to access all of that. Now with the PowerPoints, I have them set up so you can absolutely type your notes in there. You can change things around however you would like. They are going to look a little bit different from mine, but they should be pretty close. Okay. We are going to get started unless there's any questions that you guys have. Questions or concerns? No? Okay, let me get my screen shared here. Can you guys see my screen? Yes, okay. Do you see it in presenter view or do you guys see it in just like a normal PowerPoint? Presenter view, okay. There we go, how's that, better? Perfect, okay. All right, you guys. So we're going to go over what's called the nursing process, which is ADPI. You're going to hear about this a lot from here on out. And this is what you're going to utilize, and you're not even going to really think of it as ADPI anymore, but this is the process we want to start you out with. This is the basis of nursing, okay? So assessing, that's where we're going to start. That's our A in ADPI. So it's a systematic and continuous collection and validation of data from your patient, whether it's communicated or assessed via observation, okay? We're looking at all patient information. We're looking at their health status. We're looking at their emotional status. We're looking at their socioeconomic status, their resources, what they have available to them, and what they may need to either fix or make their health problem better, Okay, so there's a database, which we're going to learn a little bit more about in a couple of weeks, but the database is where all this information is stored. Okay, so that will be either the patient's record, the patient's chart. That is where that database is going to be, that has all of that information in there. Okay. So here we have a little picture here. This is our ADPI. We're looking at assessing. Okay, so we're collecting data. We're doing just as it says. We are assessing. We're going to validate that data. And by validating, what does that mean to you? Validating the data.
Making sure it's accurate.
Yes, exactly. We want to make sure our data is accurate, right? Okay, good. Okay, so here's the thing with nursing. A lot of critical thinking is involved. It's not black and white. It's very much gray. So when we assess our patient, we're going to use our critical thinking skills to determine what we think is the problem, what we can do about it. And sometimes we're going to be wrong. And so we're going to go back to the drawing board. Okay, so we're going to be using our critical thinking skills. And the more that you practice that, the easier it's going to become. Okay. A lot of fundamentals is going to be determining normal versus abnormal. So you guys are going to learn with me all of the normal states for urinary, bowel, vital signs, all of those things. We're going to look at what is normal so that then you can detect when something is abnormal when you're doing your assessments, okay? Bias is important to know and consider. We all have it, whether we realize it or not, or whether we even mean to. So making sure that if you find that is creeping up when you're doing an assessment or you're working with a patient, try to put that aside. And just remember that you were there for the patient, okay? We are going to make judgments about the data. And as I said before, that's how we're going to determine our plan. And I will talk to you more about that in just a little bit, okay? So our nursing assessments, here are some characteristics. They're purposeful. And what I mean by that is that we are assessing each individual part with a purpose. And we have a purpose for assessing the whole patient rather than if they came in for pneumonia, we're just assessing their lungs. No, we assess the whole patient, okay? It's purposeful because we're going to look at other factors that could have caused pneumonia, or what is the pneumonia affecting? What other things might be affected? What do you think I mean by prioritized? Any thoughts on that one? So we're going to look at a lot of what you guys are going to find. A lot of your nursing questions are going to be about who am I going to see first? Who is the top priority right now? Or if you're working with an individual patient, what is the top priority right now? Is their airway okay? Breathing okay? Circulation okay? Yes, then I can move on to something else. But you're always going to be prioritizing your care when you're a nurse. You're always looking at what is most important to complete right now. Okay, complete meaning thorough. Of course, we want our assessments to be thorough. Systematic, now this is something that will take a little bit of practice, but as you begin to do your head-to-toe assessments, you're going to find that you start at the head, then you might go to the feet right next, and then you might go to the abdomen, and eventually you'll get to a place where you do it just in a systematic approach, head all the way down to the toes. It takes a little bit of practice to get there, but we're systematic for a reason, okay? Factual and accurate, of course, we want our information to be accurate. And then relevant, again, that kind of goes with the purposeful. We want to make sure that the data we're collecting is relevant to the patient's problem or relevant to the patient. And then we want to record in a standard manner. And what that means is that you're going to document your assessment findings in whatever policy or procedure your facility has, okay? If you guys have any questions, just stop me, okay? So we have 5 different types of nursing assessments, which we're going to look at a little bit more closely here in just a second. But these are just the 5 major topics. And I'm going to define them for you here coming up. Okay, So the initial comprehensive assessment, that is going to be done by the admitting nurse, okay? So the nurse that first lays eyes on this patient is going to do this first comprehensive full assessment. And what that means is they're going to be taking a history, they're going to be doing the major assessment, head all the way down to toes, very, very thorough. Why do you think that the admitting nurse is the one to do this? So the admitting nurse, they're going to outline the baseline data. And what I mean by that is they're going to lay the foundation of what this patient looks like, okay? They're going to assess everything very thoroughly so that we know if there's a change, whether it be positive or negative moving forward. So they're creating that database for us. Does that make sense? Okay, so focused assessment. That's going to be more towards focusing on why the patient is here. So again, with my example of pneumonia, we're going to be focusing on the lungs and how that's affecting the rest of their body. Okay, so the focused assessment is going to be, again, on that pertinent problem that the patient came for. Now, the emergency assessment, very important. This is going to happen often in the emergency room, but what you're looking for in the emergency assessment is any life-threatening issues, okay? So ABCs, we know airway, breathing, circulation. Those are always the priority, always, 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 okay? Does anyone know what D and E stand for? So D and E are going to be disability and environment, and we'll talk more about that later. But this again happens most oftentimes in the emergency department, or if your patient has an emergency while they're in your care. Again, remember the ABCs are always the most important: airway, breathing, circulation. Now, a time-lapsed assessment, this is going to be your daily assessment on your patient, okay? So you have your nurse, your admitting nurse took your initial assessment and laid down the foundation for you. Now you're going to go in and do your assessment. Let's say the patient was admitted on Friday, and now you're here Monday morning, you're going to do your time-lapsed assessment, which is really just a way of saying this is your assessment, your first assessment, and you're going to compare the data to their baseline, which was that admitting assessment. Has there been a change, whether it be positive or negative? Any questions so far? Okay. So when we look at assessment priorities, it's important to take this information into consideration, okay? So health orientation. Does anyone know what is meant by health orientation? Health orientation is going to be how really their understanding of their overall health. What does the patient view as their overall health status? Okay, developmental stage, not only is it what age are they, but what is their true developmental stage? We have people, some patients who may have a developmental delay. We need to know what that stage is so that we can best provide our care for our patients. Culture, again, also very, very important. We're going to be making sure that we are culturally competent when providing care. So it's important if you feel that you see a discrepancy in what you think should be done with a patient, talk to them, ask them, is this a cultural thing that you don't bathe more than once a week, or whatever it might be? Get to know your patient, understand why they act in the way that they do. There are lots of cultures out there that we may not be familiar with, and actually here in Flagstaff we get a large variety of patients due to the Grand Canyon and a lot of traveling. So it's important that if we don't know that information, we ask our patients so we can provide the best care. And then what is their need for nursing? Who needs to see me first? What patient do I need to see first? What do they need from me? Okay. So we have two different things. We have a medical assessment and we have a nursing assessment. So a medical assessment is going to be looking at the pathological condition, the disease itself, okay? The nursing assessment is going to be how is the patient responding to this condition? So a medical assessment is where the physician comes up with their disease process. What is causing their illness, okay? The nursing assessment is then where we come in and we assess how is this disease affecting our patient. Any questions on that? Just want to make sure. Okay, perfect. So objective and subjective data. This is really, really important, okay? Really important. What is objective data versus subjective data? Objective is measurable. It's data that can be seen, heard, or felt by someone other than the person experiencing it, okay? So this is going to be things like vital signs, so temperature, pulse, blood pressure, respiration. This is going to be someone who is bleeding, vomiting, crying, screaming, laughing, anything that I can look at my patient and truly see happening is objective. It's observable, okay? Subjective is what the patient tells me. So pain is subjective. And that's going to be one to really remember. Pain is whatever the patient says it is. So I can't tell, I can observe and see maybe some cues that the patient is in pain, but I can't determine what their pain level is, what it feels like. Same thing with feeling dizzy. I may see cues in my patient's facial expressions, the way that they're carrying themselves, but I can't actually tell you that they're feeling dizzy, okay? So remember, objective is observable. Subjective is coming from the subject themselves, if that helps, okay? Subjective is something you cannot determine, only the patient can. And they both are very important when doing your nursing assessment. Now we have lots of different sources of data. The very, very best source of data is always going to be the patient if they are able. Family members and significant others are absolutely important as well, but the most important and the best person to get data from is the patient. Now their patient record is also another great place to get information, whether it's from this admission or a previous. You're able to look and see any information that the patient may not be able to provide, or instead of asking the patient to repeat it all over and over, you're able to read their patient record. Within their record, you're going to find their history, a physical exam, and progress notes. The medical history should be completed by a physician, and sometimes it's really great to go in there and see what everything that they are looking at to determine their disease process. The physical examination is not only done by a physician, but that admitting nurse and every nurse following. Progress notes are kind of a way for nurses, physicians, anyone who interacts with the patient to discuss how things are going on a day-to-day basis. So your admitting physician comes in and admits the patient. The next day they come in and they follow up. They talk about how the patient is either improving, not improving, what their labs might be, how they're going to change their care. Same thing with the nurse. The nurse will write progress notes indicating what is working for the patient, what is not. Consultations, those are going to be other providers becoming involved in the patient's care, whether it be respiratory therapy, a dietitian, physical therapy. There's all kinds of what we call ancillary staff members who can come in and create a plan and work with the patient as well. We really look at the holistic approach of care. We have, of course, laboratory and diagnostics. So what are their lab values telling us? Those are good sources of data. What did their MRI show? I just talked about reports from therapies, and then nursing and other healthcare literature can come in really handy, especially when you're just starting, as a way to kind of compare what you're seeing with what other people have seen before and helping you come to some conclusions. Everybody doing okay? Okay. So the skill of nursing observation, this is something that you will develop as time goes on, but you'll be amazed at how quickly you start to get a sense for this, okay? You're going to be looking at your patient, and every time you look at them, you're assessing. So every time you look at your patient, you are getting information. Are they laying comfortably? Are they sitting up in the chair? Are they grimacing? Do they have a look on their face like something is wrong? Are they breathing okay? You're constantly assessing, okay? You're going to be able to determine, as a nurse, you work so very closely with the patient. I don't know if you guys are fans of shows like Grey's Anatomy and those shows. A lot of shows depict medical care, healthcare as the physician being at the bedside most often. And that's not the case. You as the nurse are going to be at the bedside with the patient much more than any other staff member. So you're going to be able to determine, are they able to manage their care? Are they doing things for themselves? Or am I intervening with every task that needs to be completed? Every time you walk by a patient's room, you're going to look at their environment. I'm going to talk to you in a minute about what I call a drive-by assessment. And then of course, the larger environment, hospital or community, is that safe for the patient? But you're, like I said, you're always assessing, always, always. Okay. So when is your nursing history supposed to be completed? The nursing history is going to be, per facility, you'll have a procedure in place, and in lab, you guys are going to work on this to get familiar with it. But this is where you as the nurse interview your patient or the closest person to them to gather information about not only their present illness, but any past, okay? It should be done as soon as possible. And remember, that's to help us lay that foundation of their baseline data, okay? We want to identify strengths, weaknesses, what might be hereditary for them, what is newly diagnosed, what are new symptoms that they're feeling, what are potential problems that we have come up with just by listening and getting information from our patient. You're really getting to know your patient, and this is a great time for you to get a feel for, again, that health status. What do they think, their health orientation? What do they think about their health? What do they think they need? What do they feel they're missing, or what are they worried about? Okay. So let's look at the components. So there's 4 phases of a nurse interview, okay? There's the preparatory phase, and that's really when you as the nurse are going to gather all of the things that you need in order to do this, whether it be the list of questions, whatever it might be, it's you getting prepared. You have the introduction phase, okay? So that's when you're gonna go and introduce yourself to the patient and let them know what you're going to do. The working phase is going to be where you carry out the interview, and then the termination phase is when you complete. Now, these can take quite a bit of time, and so you want to make sure when we talk about priorities that all of your important nursing tasks that have a time, it was the word I'm looking for, that are time sensitive, that those are done before you sit down to do this nursing history. Okay, so the physical assessment, which you guys are going to work in lab constantly with this till you get it down and feel really comfortable with it. This is where we are going over the patient's physical well-being. We are assessing their physical well-being. And we as nurses are able to identify problems that exist that the patient may not have come in for. Let's say again, I use pneumonia for my example today. They came in with pneumonia, but we're listening to their heart sounds and we notice that maybe it's irregular. So they didn't come in because they had an irregular heart, but we may have identified that that's a problem. Okay, now we're also going to establish interventions, which we are going to cover in the next couple chapters. Clinical reasoning, again, this is something that as you guys go on, you're going to add into this bucket of knowledge. So the more you do clinical assessments and work with patients, the more broad this is going to be. You're going to make judgments about data. You're going to just, we already did this slide, I'm pretty sure. Normal versus abnormal, okay? So problems related to data collection. it's really important that we gather and document all of the information, okay? We don't want to omit anything that may be important. We may have heard an irregular heart sound and thought, well, they're here for pneumonia. I'm sure the doctor's aware. We don't ever want to do that. We want to make sure that if we find something or something is not totally normal or already documented, that we inform the right people, okay? Establishing rapport and partnership with your patient is really, really important. If we don't build that foundation of trust immediately, the care with our patient will suffer, not only for you, but also the patient. If you don't establish that rapport right away, you'll notice that it just isn't working. And sometimes that's okay. Sometimes personalities clash, and it's not the best for you to care for that patient that day. And it's really great. Nurses are really good at helping each other out and, you know, switching patients or whatever it might be. But try your best to establish that rapport and trust right away, okay? Making sure that you record your interpretation of data rather than, or making sure you don't record your interpretation of your data rather than what you observed, okay? So you don't want to put your emotions in the charting. You don't want to put anything other than what's truly observable, okay? And then of course we want to make sure we update the database. When we verify data, we want to verify when there's a discrepancy between what we see and what the patient is saying. So a good example of this that we actually see somewhat often is a patient who is laughing, but telling us they're experiencing a lot of pain. We want to validate that. You tell me that you're in 10 out of 10 pain, but you're laughing at your TV show. Can you tell me these don't go together? Okay, so understand why. And then patient may say, this is how I cope, or you may discover something else, okay? Also, when to verify data is when you lack objectivity. So when you don't have a lot of the measurable data, you want to ask more questions to make sure that you have the subjective data correct. Inferences, we're wanting to make sure that we are validating our data by using the right equipment. So let's say a blood pressure cuff. When you guys go to lab, you're going to see that there's multiple sizes of blood pressure cuffs. And if you don't use the right cuff, you can get a number that is actually incorrect. So making sure you have the proper equipment, okay? Making sure you're using clarifying statements so your patient truly understands what you're saying. And again, that checking the consistency of cues like we just discussed. Documentation is super, super important, and I believe in a couple of weeks we're going to cover that in lots of detail. But you want to make sure that you are documenting everything objectively. If there is subjective data, of course that's important. You can add that in there, but making sure that you are not putting in there your own emotions, okay? It's objective data. What did you see? And making sure that you do it within a timely manner. HIPAA, you guys, if you haven't already, will complete a little course on HIPAA. Super important, and you're going to hear about it forevermore. Can anyone talk to me a little bit about HIPAA?
Just keeping your patients' like rights and stuff, everything confidential.
Yes, exactly. So the things you would be surprised at the things that are considered private information. It's truly everything about the patient, okay? And so it is so important that you as the nurse protect that. You protect all of that information. Now, if a family member is in the room and you need to discuss a plan of care with your patient, you just need to clarify with the patient that they're okay with this family member or visitor, whoever, to be a part of it as well. That is okay, but what's not okay is answering the phone at the nurse's station and telling whoever's on the phone a full, thorough, detailed message about how a certain patient is doing. And we'll talk more about this when we talk about communication. But again, HIPAA is super, super important. I have 2 people that I used to work with that by no means meant to cause any harm or do anything wrong, but were fired for breaking HIPAA guidelines. So just, it's super important, taken very seriously. On this slide, there's a couple links if you guys want more information, but again, I know you take a course on it as well. Okay, so now that we have assessed, we're gonna move on to diagnosing. Okay, so we have done our full comprehensive head-to-toe assessment. We've interviewed our patient. We have all of this data. Now, what are we gonna do with it? Okay, let me move on to the next chapter. While I do that, please let me know, does anyone have any questions? I know this is a lot of information for day one, but again, I just want to kind of lay the foundation. Okay, you guys see my screen okay? Oops. Okay, so nursing diagnoses, okay? These are going to be very different from what a medical diagnosis is, and we'll talk about that a little bit more in a minute, but they are actual or potential problems that can be resolved by individual actions by the nurse. Now, that's a mouthful, but what that means is you, as the nurse, can do any intervention related to this diagnosis without the need of an order from anyone else. So it's not something that needs to be ordered by a physician, a respiratory therapist, pharmacist, nobody but the nurse. So this intervention is completed by you without needing permission otherwise. Okay, so this is nurse related. Hopefully that makes sense. We'll go into more detail here in a minute. Now, the really cool thing is there's what's called NANDA. It's in your guys' Lippincott, and there's also hard copies of them everywhere. They have come up with hundreds of nursing diagnoses that are pre-built, and that's what you're going to choose from, okay? You can look at it, whether you look at pneumonia, you pull up pneumonia and look at all of the different nursing diagnoses that way, or you may say, I know they have ineffective airway. I'm gonna look at that. Okay, so we'll dive way more into it, but I wanna lay the foundation. Diagnoses done by nurses are created by you and carried out by you, okay? So the purpose of this diagnosing is so that we can create that plan of care. If we get a nursing diagnosis, we've determined that the patient is most at risk for, we'll say, the ineffective airway due to their pneumonia. So they're having a hard time breathing because they have pneumonia. That is what's important. Now I'm gonna get interventions that are related to that I can carry out, and I'll show you how that works. But again, we want to make sure that the nursing diagnosis is pertinent to their health concern, whatever the medical diagnosis was, which is pneumonia. We are then going to go in and find a nursing diagnosis that applies to the patient that provides us with interventions to help make this patient better, okay? So here we have our assessment. This is where we started. We used our clinical reasoning to draw conclusions to then come up with a diagnosis, okay? And again, these diagnoses are already built for you. It's just a matter of choosing the one that is most appropriate for your patient. So it's important that we look at these things very closely. Infection prevention, huge, okay? And safety. Those are oftentimes going to be some of the diagnoses that we pick are going to be related to these, okay? Reduction in infection transmission and making sure that our patient is safe. Any questions so far? Okay, how is this illness affecting the patient? Is there a diagnosis that is guided towards the effect on the patient? If so, maybe we find that to be the most important, okay? What are some complications that might be involved by using a certain diagnosis? And then of course, initiating those urgent interventions as soon as possible. So basically what this is telling us is that we need to look for evidence of all risk factors, okay? So if you identify a risk factor, you want to control them or prevent them. So let's say that we think our patient is at risk for falling, but maybe they haven't fallen, but we see they're a little bit unsteady. Now we have made that our nursing diagnosis, risk for fall. What interventions can we put in and put in place to prevent this from happening? So they're not always going to be something that already happened. We may look and see, ooh, this patient makes me nervous for this. I'm going to create a nursing diagnosis, prevention of falls, where all these interventions will then be given to me to put in place so that it doesn't happen. Okay, again, safety needs are always the most important. So we just talked about this a little bit. That nursing diagnosis, remember, is a problem that the nurse can treat independently. The medical diagnosis is the problem in which the physician guides the treatment, but again, this is going to be pneumonia is the medical diagnosis, and they are going to have a list of interventions that we might carry out, but they have ordered, such as giving a medication. We may carry out that intervention, but they had to order it, which is called collaborative problems. So physician prescribed interventions, okay, we may carry out the intervention, but we couldn't have done so without the order from the physician. Does that make sense? Yes, no, maybe so. Oh my gosh, sorry. Okay, so this is just a picture of collaborative problems and how they work, okay? So here's their diagnosis. This is what the physician wants done. Here's the study that was done. Again, they're more than one entity working together for the patient. So as you go through nursing school, you're going to become more familiar with nursing diagnoses, and there's going to be, I would say, a good top 20 to 25 that you're going to see and use most often. There's many more out there. In a hospital setting nowadays, they are predetermined for you or recommended based off of the patient's admission diagnosis. Okay, so respecting your clinical intuition, you may not feel like you have that yet, but you'll be surprised how quickly that's going to arise. If you feel that there is something wrong, take charge of that. Find a nursing diagnosis that can work with it and help your patient. Okay, again, recognizing personal bias is super important. We want to try to keep an open mind when working with our patients. These are just things that will help us build that rapport, that trust. Okay, respect the opinions of your patient and others. Listen effectively. It's important that we hear our patient. They know their body more than anyone else. And although we may say, I've had 10 patients with pneumonia and this plan works, if this patient tells you it's not going to, listen to that. They know their body. Okay, so we've got the 4 steps of data interpretation. We recognize significant data. So we're comparing to standards. We're not comparing to their baseline, but we're comparing to the norms of an adult, okay? So we'll use respirations, for example. 12 to 20 is the norm for an adult. We're gonna assess our patient's data respirations. Let's say they're breathing at 28. We recognize and we compare to the standard of 12 to 20 that is elevated, okay? Recognizing patterns or clusters, meaning, is this happening consistently? Are these 3 things happening together? Patterns and clusters with your patients. How are they working together? What might they be? What about strengths? What are your patient's strengths? We don't always want to focus on the negative, right? We want to embrace what they're really good at and help them to use those tools to get better at other things. And then, of course, reaching conclusions. So we have 3 different types of nursing diagnoses. There's problem-focused, risk, and health promotion. Problem-focused means the problem already exists, okay? Risk is what we're worried could happen. And then health promotion is going to be a readiness to enhance. So this is when your patient is ready to improve something within themselves. Does anyone have any questions about that before I move on? So there's formulation of nursing diagnoses. We have the problem. What is unhealthy about the patient? Etiology is the related to factor. So let's use pneumonia again. We're going to say they have an ineffective airway. That is the problem. It's related to their pneumonia, okay? As evidenced by, so defining characteristics. This is where you're going to put your subjective and objective data. So let's say our objective data for this diagnosis is respiratory rate above 28 a minute. Okay, that is not that's not a good respiratory rate, right? And that's where we're going to define the characteristics that make that diagnosis appropriate. Does that make sense? Yes, no. Are you still with me? Okay. So here's how we write a nursing diagnosis. We begin with the problem. Remember, we're beginning with what is causing us to want to intervene. We make sure that it has that related to factor, and then the as evidenced by, as we just talked about, okay? And making sure that it is non-judgmental. The NANDA provides you with all of the correct terminology. You don't have to make any of this up on your own. It's all provided for you, and we will work on that in lab. So you want to make sure that you validate it, right? So making sure, although let's say you looked up pneumonia and you found a list of 10 diagnoses and you just picked one random one, you have to validate that it's actually appropriate for your patient. Does this actually go with what's going on with the patient? And then of course, making sure that what you choose, the interventions that are listed are nursing specific. The nurse itself can carry out these interventions without an order from anybody else, okay? With a nursing diagnosis, it's ever changing, okay? So you're going to look at your patient, you're going to make changes to your nursing diagnosis, to your interventions. It's really, a lot of it is trial and error. Did this intervention help? Did it not? What can I do to make it better, okay? If I need a new nurse, let's just say the nursing diagnosis I picked is not working for my patient. What am I'm gonna terminate it, start with something new, okay? Making sure that you document them, super important, because not only will you use this, but those nurses that are caring for the patient after you will use them as well. Making sure you communicate with the patient about your nursing diagnosis. You wanna make sure that they agree. Are we taking care of what they're here for? Are we treating them for what they believe that they need? Okay. Again, individualizing patient care, just like I said, it's so important that we make sure the care that we're providing for our patients is what they're looking for, okay? They came to us for help. Are we meeting their needs? Some limitations for nursing diagnosis, if we use them inappropriately. So if we just pick a diagnosis that really truly isn't relevant to our patient, we're not actually helping them, right? And same thing, if you pick a diagnosis that is not really nursing related, you're not able to perform a lot of the interventions. When writing these, you just want to make sure, I would always use the guided words that it provides for you. That way you don't have to make anything up, okay? And then you know you won't be doing anything wrong. Making sure that you use your as evidenced by with real, actual, subjective, objective data from your assessment, okay? Making sure we do not include any judgment in our nursing diagnoses. Super, super important. We want to leave our bias, our judgment out of it. And also don't include a medical diagnosis in the statement, okay? again, if we put in a diagnosis that we just think might be appropriate but haven't validated, then we have a problem, right? We're doing interventions that aren't helpful for the patient. It's not helping the patient, and it's not making our care for that patient easy either, okay? We want to make sure that we compare our nursing diagnosis and all the data to the documentation of the patient. Is this truly accurate? Whew, okay, everybody, are you guys with me? Still, okay. I know this is a lot, and I apologize. And this is not my favorite to do it over the computer. I do really just want to lay this foundation, and please stop me if there's any questions that you have. Okay, everybody's doing okay. Do you guys need a little break for a minute? No breaks? Okay. All right, I'm gonna just keep trucking along here, okay? Let me pull up the next one. Oops. Let's see here. Okay. So this is where it starts to get a little bit fun. Okay, so this is where all of our hard work of our assessing and coming up with the diagnoses, now we get to plan our interventions for our patient. Okay. So what we're going to do, we're establishing priorities. So remember, in nursing school and nursing in general, priorities, safety, always super, super important. Okay, so what priorities do we have? We want to pick a nursing diagnosis that, of course, we can do the interventions, but actually has a lot of value to our patient. How can we then carry out these interventions? Can you guys still hear me? I lost my ear. Okay, so you're going to identify and write the expected outcomes for your patient. This is absolutely where you're going to wrap your patient into this. What do they want to achieve? Here are the outcomes we're trying to get to, okay? Evidence-based nursing interventions, you're going to learn a lot about evidence-based practice, but really what it is the fact that whatever you're doing is backed by research. So evidence-based practice means if something is evidence-based, there's research to back it. There's research to say this actually works, okay? And then communicate the care plan. Not only are you going to tell the patient and include them, but you're going to communicate this with other staff members, with the oncoming nurse, physical therapy, whoever needs to be involved, you're going to communicate that information with them. We all want to be on the same page so that we're all working towards the same common goal. Okay, so there are some things that of course come into play. These are the standards. So making sure that everything you're doing is legal. There's national practice standards. There's all of these different standards. Now, where you're going to find this information is within your facility. Okay, I'm not going to go into specific detail because it's different everywhere, but making sure that you're choosing things that are within your scope that your facility allows. Okay, so here's what a formal care plan allows. Now, you guys are going to work on care plans throughout nursing school, and they're very in-depth. When you get to nursing at the bedside when you have your degree, it's not as in-depth. A lot of it's built in for you, but they're accomplishing the same things, okay? You're individualizing care, right? You are creating a plan for your patient that is specific to that patient. You're setting priorities, setting goals for your patient. You're going to communicate this information to, like I said, the patient, any of your colleagues that need it. We're of course going to promote continuity of high quality care, meaning that's why it's so important to communicate. If I don't tell the oncoming nurse what the plan is for the patient, they may come up with their own, right? And now we're doing too many different things. We're going to coordinate care. And what that means is involving people who we need. So let's say that one of our outcomes has to do with ambulation. Well, we might need to involve physical therapy. We might need to coordinate that care, okay? We're constantly assessing, and with assessing, you're actually evaluating. They kind of go hand in hand, okay? So you're constantly looking at, is this working for the patient? Are they able to, do I really think they're going to achieve this goal that we created, or do I need to modify it? Okay, I'm of course going to record all of this information. And this also is going to promote your nursing development. So every time you work with a patient, you're adding little tools to your bucket list, okay? So every interaction that you have is going to help you in further situations as a nurse. So again, what we're trying to accomplish in this stage is to come up with ideas for an outcome. How are we going to get to our outcome? How are we going to reach our goal? Okay, so we of course need to know our patient's expectations. What do they want to achieve? And now we are going to come up with interventions to get there, okay? Again, you need to be familiar with your facilities, policies, and procedures. I have worked at a few different places and they're all very much the same. They use the nursing standards of care. And again, NANDA is where we get all of our nursing diagnoses and interventions, and they all approve and use those. Remember that this is all about the patient, okay? What we're trying to do is help the patient reach their full potential and keeping the big picture in focus. Now, this can be difficult, and I have to admit that I just started working at the rehab hospital, and I didn't really realize how much the big picture played in effect. Working in the hospital, it's very much acute care. You're just trying to get them to the next phase. When I work at the rehab hospital, I see they are looking at the entire big picture. Things like navigating different sidewalks. So they have multiple levels of sidewalks at the rehab center so that the patient can learn to navigate those things. They have in every room the transition of carpet to tile with a walker, with crutches. They really look at the big picture. You'll often see that in acute care, like in a hospital setting, the big picture is a little bit more narrow, if that makes sense. Again, you're going to use your clinical experiences from the past to kind of help guide you. Sometimes it will work, sometimes it won't, and then you'll go back to the drawing board, okay? Valuing collaborative practice, I love that. Talking to your teammates, talking to your fellow nurses, your PCTs, your physician, whoever it might be. Here's what I'm thinking. What do you think? This has worked in the past. It's not working for this patient. What ideas do you have? Okay, this is very much a team sport. Respecting your clinical intuition, again, that's going to build very quickly. If something doesn't feel right, follow that, okay? And again, we're recognizing your personal biases. So we had our nursing diagnosis, and now we're going to pick our interventions. So there's comprehensive planning. There's initial, ongoing, and discharge, okay? The initial is performed by the nurse with the admission history. Ongoing is going to be carried out by any nurse who interacts with the patient. So this is your care plan, okay? So your ongoing care plans are those that you choose, and then the nurse following you are going to continue to use, or you are that following nurse. You're going to continue with that ongoing plan. The discharge plan is going to be carried out by the patient who has worked most. The book says the nurse who's worked most closely with the patient, but it's oftentimes that last nurse that's with the patient. Again, you're going to be doing your discharge planning then. Okay, so ongoing is where you're going to see the majority of the care plan. Okay, so initial, we're going to just go into a little bit more. This is the nurse who does a physical assessment. They're going to address problems listed, and they're going to identify appropriate goals, okay? Then ongoing, we are going to carry out those interventions. We're going to keep our records. We're going to make sure that we're documenting all of this. We may develop new diagnoses. We might say, this is great, but let's add this as well. I've noticed that my patient is a little unsteady, so we're also going to add that they might be a risk for falls, okay? Making sure their outcomes are realistic, and develop new ones if needed. Although we may want our patient to be able to walk 500 feet up and down some stairs without being short of breath, that might not be realistic. And the problem with that is that then discourages your patient. If they're not reaching their goals, that's going to discourage them. So we want to make goals that are appropriate and achievable, okay? And then discharge planning, again, we're looking at how are we going to get our patient to the optimum level when they leave. Discharge planning, remember this, starts from the minute the patient is admitted, okay? Because what we're always looking at is the end goal. What are we trying to achieve? So remember, discharge planning starts at the beginning of their admission. We're wanting to make sure that when they leave us, they are in better health than before they got there, okay? Making sure that we use lots of different methods to help our patients achieve their goals, whether it's counseling, teaching. We'll learn about how to do specific teaching in lab. You guys will learn about the teach back method, see one, do one, teach one, okay? So show your patient how to do something, have your patient show you that they know how to do it, okay? I can tell you from a patient side of things that my littlest boy, he was in the NICU when he was little, and he had to have his nose suctioned out with saline, which I was like, oh yeah, totally easy. And the nurses kept asking me, do you want to do it here before you go, or do you feel comfortable? And I was like, I feel totally great about it. And when I got home, I was like, what do I do? So really encourage your patients to act out those things that they're going to do when they go home. Okay, priority, right? We always have priorities. What is the greatest threat to the patient's well-being? Those are going to be the priorities. Those are going to be the things that you're going to work on the most. Then we have the non-threatening. And then we have the diagnoses that are not specifically related to their current health problem. So that might be that enhanced readiness to have better nutrition, or something that's not necessarily pertinent to right here, right now. But again, priority, right? ABCs, what is the most threatening? Let's work on that first. Hopefully you guys have heard of Maslow's hierarchy of needs. He has come up with this, and we in nursing use this quite a bit, okay? So we have our physiological needs. We have our safety needs, love and belonging, self-esteem, and self-actualization. And these are in order of importance. Now, his hierarchy of needs is usually in a triangle shape. Is everyone familiar with that? Oops. Oh my gosh, you guys. Sorry, just trying to read my chat. Yes, okay, perfect. Plays a really big role into nursing. So when why we're talking about it now is when you're planning your care for your patient, your interventions, you want to take into consider these hierarchy of needs, okay? They're all important, all important. We've talked about this already, but again, individualizing that care. What does the patient think is important? What do they want to achieve? Can you make that a priority? We want the patient to feel in control, okay? We know that if they are taking charge of this, they're more likely to continue on, okay? Anticipation of other needs, again, this is kind of that intuition that you will gain with experience. You're gonna anticipate needs. So let's say that patient who we think might be at risk for falling, well, what might they need? Do they need a walker at home? Do they need an assessment of their home environment to determine safety factors? Okay, so those things will come as you gain experience. Again, we just talked about this, establishing priorities, making sure that you know what is the most important, what can wait, okay? What is your responsibility, and what are things that someone else can carry out, okay? This is important too. Oftentimes things change with our patients, so it's important that has something changed that we now have a new priority, okay? Have they fallen and now do they have a bleed in their brain? Did something change that now our priorities have changed? Are there relationships between multiple diagnoses that kind of can be brought together and worked on together? Or is there one that's required to be done before the next? Now, long-term versus short-term, this is also important. Long-term goals are usually those that are going to last for a week or longer, okay? Short-term goals, I prefer that short-term goals are done on a daily basis or a shift basis, because what this does is it encourages your patient. If you create a short-term goal, by the time I leave today, you are going to ambulate down the hallway and back, Okay, that's something that's attainable that day, which encourages your patient to get it done and then see that they did so. Okay, so when you guys do your care plans, I really encourage your short-term goals to be one that you as the nurse can evaluate during that shift. Okay. Again, patient-centered outcomes. What can we do? What does our patient want to get out of this? How can we help them achieve that? And we need to make sure that we know, what is their expected length of stay? Did I create a goal that's unreasonable based off of how long they're going to be here? What about their overall prognosis? What about other therapies that are involved? Okay, so looking at the whole picture, I want to make sure I pick interventions that are going to be able to be carried out while in our care. So these are the Institute of Medicine's 6 aims to be met by healthcare systems. Okay, so again, we want our quality of care to be safe. We never want to have injury. We want it to be effective. Okay, we want it to be patient-centered, timely, efficient, and equitable. Meaning that it's the same for everybody. Okay, so this is really what we want to look at. Did we provide safe and effective care? Was our patient involved in the process? Did we do so in a timely manner? Did we avoid waste? And was this care something that could be provided to multiple people? Again, we have different outcomes, okay? Cognitive is going to be a change in behavior or knowledge, okay? Psychomotor is going to be more of that physical, or do they have a new skill, or did they improve on a skill? And then affective is going to be changes in values, beliefs, and attitude. Okay, clinical, functional, and quality of life outcomes. Quality of life looks more at how can we make things better for them? What can we do to have a quality of, what goals can we create to improve their quality of life? Functional, again, is going to be what can we do to get them back to their baseline, so their normal functioning level or even better, okay? And then clinical outcomes are going to be really looking at health issues, okay? So they had pneumonia, they had an ineffective airway. What outcomes are clinically based that we can improve that? So that would be clearing their airway, having their oxygenation stats back to normal. Does anyone have any questions? Okay. So when you're writing your outcomes, they should have the subject, which is either the patient or the body part of the patient, the action that the patient is going to perform, conditions, whether it's circumstances that they're in or that they will achieve. And then when do we want this to happen? When is our expected time of achievement? So again, that short term would be the end of shift. The longer term would be maybe by in 10 days, the patient will be able to perform X, Y, and Z. SMART goals, you're going to hear a lot about SMART goals. These are specific, measurable, attainable, realistic, and time-bound. So we've kind of already talked about it, but again, specific, meaning there's not really room for misinterpretation, okay? Measurable, can I truly evaluate and measure that this was completed? Attainable, is it possible? Realistic, is the patient really going to be able to perform this? And then again, not time bound, when do I expect this goal to be met? So when we talk about common errors in patient outcomes, we're using things that are not, verbs that are not measurable. So we don't want to necessarily talk about that subjective data, right? We want to look at the things that you and I can measure, that we can see to truly validate that it's happened. Okay, writing vague outcomes, again, being specific and precise, really, really important, so that the next person coming onto shift knows exactly what they're expected to try and help this patient accomplish. So we talked a little bit about this as well. We have different types of interventions. We have nursing initiated. That's an autonomous intervention that nurses can execute to the benefit of the patient in a predictable way related to a nursing diagnosis without any other person involved. Physician initiated is going to be an intervention that you as the nurse carry out, but was ordered by the provider. whether that be a medication, anything that the doctor writes as an order, you must carry out as the nurse. Although they initiated it, you are doing the intervention. Okay, so that's physician initiated. And then collaborative is going to be, let's say physical therapy said, please ambulate patient 3 times a day. That again is going to be written, the order comes from someone else, but the nurse does the intervention. Does anyone have questions on the differences in those? No? Okay. So things that we need to make sure that we look out for, we want to monitor their health status. We want to reduce the risk of any harm. We like to resolve problems. We like to facilitate independence. Now, I have to tell you, I struggle with this because and as nurses, we tend to be this way. We're doers, we're givers, okay? So you really want to promote the patient to be as independent as possible. I oftentimes find myself providing too much assistance, and that's really not actually helping the patient. So I have to remind myself, take a step back and let them really, truly try and do it themselves, okay? We want to make sure that we're promoting the very best of our patient, whether it's physical well-being, emotional, behavioral, all of that. We want to encompass that and try and help them reach their full potential. A consultation is going to be if you reached out to someone else, or maybe a physician did, another entity of care. So let's say our patient with low oxygen, we are going to involve respiratory therapy, or a patient who's at risk for falls, we're going to get physical therapy involved. Okay, so that's just going to be adding in additional support to help us obtain these goals that we've created for our patient. All right, so we have types of institutional plans. There's computerized care plans. Those are the plans that you'll see most often out in the real world. You guys are going to be doing your student care plans. Concept maps we'll talk about a little bit later. And then change of shift report. So you're essentially going to go over your plan of care and your assessment with the following nurse. And then you, as the nurse coming on, will have that report given to you. So it's a way to make sure everybody is communicating and on the same page. Same thing with multidisciplinary care plans. That means that the physical therapist and the nurse and the respiratory therapist are all involved in the same plan of care, working towards the same goals. Okay. How's everybody doing? Doing okay? Okay, does anyone have any questions for me? Did I go too fast, too slow? Okay, these are so good. All right, let's just breeze through these next 2 chapters, and then we'll take a break and we'll do some practice questions together. And then we'll dive into some more fun, which is vital signs. Okay. So if we think about it, we have discussed now, we have done our assessment, right? We have created a diagnosis and we've created a plan. Now we're going to implement that plan, okay? So now that we've done all of that hard work, now is the fun. We get to put that into action, okay? So the purpose of implementation is to help your patient achieve those goals, of course, to promote health, prevent any disease, restore health, meaning that we get our patient back to a level of functioning that they used to be. And then, of course, facilitate coping with altered functioning. So let's say our patient had a stroke and we know that they're not going to go back to where they were before, right? They're not going to be able to ambulate or do some of the things that they used to in the same way. How can we help them cope with that? Okay. All right, so the reasoning that we do this, of course, we're wanting to carry out that plan of care. We're wanting to help them achieve those goals. So we're making sure that we have research, again, that evidence-based practice to support the interventions that we're going to be doing. And then we monitor, and another word for monitor is assess or evaluate. How is the patient responding to these interventions? Are these not working? Do I need to go back to the drawing board and pick something else? So Alfaro's rule is to assess, reassess, revise, record. So again, as I talked about, you're constantly assessing and evaluating your patients. Is this working? Maybe today's just not a good day, or maybe yesterday wasn't a good day, now today's not a good day. Do I need to go back and make a different intervention, a different plan? What do I need to do? Okay, and of course we're gonna record, we're gonna document that. So for you guys, this is for organizing your clinical responsibilities, making sure that you know how your patient wants to be addressed, why are they here, what is their current health status, what assistance do they need for basic human needs, what are their priorities, what teaching, counseling do they need, and any special family needs. So this is just kind of a way to look at the holistic care of the patient. It is important that we know what our patients want to be called. That's just part of building that rapport, that relationship with your patient. Okay, so implementing these guidelines, making sure that you are working with the patient. Okay, you are talking with the patient, making sure that what you guys are doing matches with what they want to do. Now, involving the family is also super important, as long as the patient wants it, because we want as many people involved in promoting this care possible. So they may be going home, and we want the family involved as well, so that they can help and keep continuing to encourage your patient to reach those goals. Okay, again, constantly reassessing. Approach the patient competently. So really all that means is going in there with confidence and talking with them with confidence, okay? And of course, caringly, we want to make sure that the patient feels as though they can confide in us and that we're here for them, okay? We modify them as needed. If the interventions that we've come up with are not working, let's change them. Let's make it better. Of course, making sure they're consistent with standards of care. Again, those interventions are already written out for you, so you shouldn't have to worry about that. Making sure that you're looking for the best possible interventions. And then, of course, you're going to want to make sure that you choose nursing skills and interventions that are obtainable, okay? The more options we have, the better for the patient. If they're able to look and say, "Ooh, I can do this and this and this," or "I want to work towards this and this, but not this," that's important, right? We want to know what their goals are and how we can help them achieve them. Okay, so we have different types of interventions. Those are that are providing direct and indirect patient care. What that means is that you as the nurse are providing that care. You're interacting with that patient while that care is being provided, okay? There are interventions that have to do with patients, family, and individuals, okay? Those are gonna be interventions that the patient or the family is going to help with. And then there's nurse-initiated and other provider treatments. So we talked about those as well. So those are gonna be those interventions that are initiated by others. So when you're implementing the care for the patient, you're always going to want to see, does the patient still need assistance with this? Do they need me to just stand by and observe and help encourage? What do they need? We don't want to create a plan with interventions and never progress, right? We want to adapt those interventions to where they currently stand. Promoting self-care is what I talked about earlier. Again, some of us, like me, have a really hard time promoting that because we want to help our patient. We want to do it for them. So making sure that you encourage them to do it themselves, okay? And of course, again, we want to help them achieve those outcomes. As we talked about before too, we want to make sure we're reassessing, right? We're constantly reassessing. We're clarifying, we're organizing, we're preventing errors and omissions, and that's by being thorough, okay? Thorough and complete when we're doing our assessment, when we're looking at how our patient is progressing. When we're teaching our patients, again, we want to make sure that we're teaching them evidence-based procedures so that they are doing what we know works, okay? Again, making sure that it is specific to professional standards, and that they're safe for that patient. So we may evaluate and say, ooh, this patient, it's not safe for them to try and ambulate 50 feet. So let's scale that back and try 10 feet today, okay? Any questionable orders, if there's something written that you don't quite understand, don't try to carry it out. Make sure you get clarification before doing so. We kind of talked about this when we're assessing developmental stage. You're going to hear that in every chapter that we discuss. That's really looking at developmentally, where are they? Are we making sure that our interventions are appropriate? Okay. Also, culture and psychosocial is super important. Again, we don't want to encourage things that go against their cultural or religious beliefs. Okay. The variables that we have are different. There's constantly new research being implemented. So there could be differences from one to another. The standards of care change, but again, all of that should be up to date within your facility, okay? Reasons for non-compliance are of course gonna be that the patient doesn't understand what we're trying to achieve. They didn't take part in this creation of their plan of care. Their family doesn't support them. Here in Flagstaff, we have a common population of Native Americans, and we have to make sure that when we're creating their plan of care, that we know that when they go home, they're going to be successful. Some people on the reservation still don't have electricity and water. So we need to know that to make sure that when we're setting them up, we set them up for success. So if they don't have access to those things, what can we do to make sure that they end up in a safe environment, okay? Healthcare costs are always a concern for a lot of people, and making sure that they know when they're here with us at the hospital, we are there to take care of them, and there will be no corners cut related to cost, okay? Now, delegation, again, we're gonna go into it in a later day, but I do want to go over this just briefly. Now, delegation oftentimes is thought of, I'm asking someone who has, like a tech to do something for me. But I have to tell you, you can delegate to anyone. You can delegate to your charge nurse. You can delegate to your PCT or your unlicensed personnel. You can delegate to your colleague that's sitting right next to you. Delegation is not always delegating, I hate to say it like this, but to someone who is their degree status is below, okay? It's not, that is not true about delegation. You're asking for help. That's what you're doing when you're delegating. So you are going to determine who you're going to delegate to based off of your task, okay? So again, making sure that when you delegate to someone, you know they are allowed to perform the task, that the circumstances are right, meaning it's safe. So the right person, is it going to be a charge nurse because I need a medication given? Or could it be a PCT or a CNA because I need a bed changed? Okay, making sure that the person you're delegating to understands, you have given them the appropriate directions and communicated what you need. Supervision and evaluation. Now with that, that means that you as the nurse, if you delegate any task, that you follow up to make sure it was done and done completely, okay? Oh, we are done with that one. Questions? Okay, all right, you guys, here we go. Let's do evaluating and we'll take a quick break. All right, so here's the fun part, which we're truly doing all the time. We are evaluating, okay? So we, together with the patient, are going to evaluate and decide, did we achieve the outcomes that were desired? If not, let's go back to the drawing boards, okay? What helped the patient achieve those goals? What didn't help? What did we need to do to modify that plan of care, okay? Again, the purpose of this is to let the patient's achieved outcomes be known, right? We want to make sure that we get to those achieved, or that we get to those expected outcomes, that we achieve them, and how do we help our patient get there? So there's 5 elements of evaluation, okay? So we have the criteria and standards. We have how we're gonna collect that data. We're going to, how do we interpret findings? How do we decide for sure that yes, this was achieved or no, it wasn't? We're documenting that, and then we're terminating, continuing, or modifying the plan. So we're constantly evaluating or assessing, right? So when we do that, if we decide our patient has met their goals, we terminate the plan because the plan is no longer needed, okay? If we determine that we need to continue the plan because we haven't quite achieved, all our interventions are working really well, but we need to continue before we meet those outcomes, perfect. If we need to modify the care plan, so we're working on our outcomes, but we're just not quite, we're not really helping the patient get to where we need to modify that care plan. Maybe that means we extend our time period. Maybe that means we change some of our interventions, okay? So we can terminate once it's complete, we can continue the care plan, or we can modify. Whoops, which I just went over. So again, terminating once it's achieved, modify if it needs to be, or continue. So we have 4 types of outcomes. We talked about this in a previous chapter. We have the cognitive, which is going to be knowledge, psychomotor, which is going to be skill, affective, which is going to be a belief, a value, a feeling, an attitude, and then physiological is going to be more of a medical, so an improved health status. How do we evaluate that these things were done? So if it's going to be cognitive, ask the patient to explain to you. Okay, if it's psychomotor, have them demonstrate the skill. Affective, that's where you're going to observe. Is their attitude, does their attitude seem better? Do they seem like they're in a happier state of mind? Physiological, you're going to compare data. So let's say it was their oxygenation that we wanted to improve. Is their oxygenation stat currently better than it was when they arrived? Okay. So evaluative criteria versus standards. Criteria is measurable qualities or characteristics, okay? Standards are levels of performance expected. So for criteria, they're going to describe the levels of performance by stating the behaviors of the nurse or the patient, whereas standards are already predetermined, okay? They're basically the foundation of how you're going to carry out those actions. Time criteria is super, super important. We already went over this, but again, when do we expect this goal to be achieved? Is that working? Do we need to change that? Do we need to look and say, well, we're getting there, but let's add another couple days, okay? Again, do not wait till discharge. Remember, discharge planning starts the day of admission, okay? Because we want to make sure we're progressing and getting to the goals that we have created. We don't want to look on the very last day and go, oh gosh, did they do X, Y, and Z, right? We want to make sure that we're working towards that the entire length of stay. So the variables that can affect outcome achievement, of course, the patient. Let's say that they decide they're done. They don't want to try to ambulate any further. They don't want to try anymore, okay? They refuse. When that happens, we want to go and work with our patient and say, okay, I understand this is not working. What can we do? You want them to leave your facility having accomplished something. You want them to feel confident in their abilities, okay? That might mean that you create a new care plan that's maybe going down a different path, but we want to make sure we involve them the entire time and come up with plans that they're willing to do. Nurses, burnout is something that you're going to hear a lot about, and I think a lot of the media lately, we hear a lot about it just because of COVID and how it can be so very much exhausting for nursing. So if the outcome is not met due to nursing, it's oftentimes burnout. If you're feeling like you are burnt out, you're not able to help your patient achieve their goals, then you need to take time off, do something to get yourself back into that group. It is not fair to the patient that they don't reach their goals because of how we're feeling, okay? Inadequate staffing, again, something we're hearing a lot about right now. If that is the reason for why outcomes are not achieved, that's not good, but we also then need to look and evaluate our plan and decide, do we need to make changes to make sure that the patient is getting the very best from us? Evaluative statements. So did they meet it? Did they partially meet it, or did they not meet it at all? And then you're going to want to provide evidence. So if they met it, yes, they ambulated 500 feet up and down the stairs with no problem. Partially met, they ambulated up and down the stairs 500 feet and took 3 breaks. Or they did not attempt, or they were unable to ambulate 500 feet. Okay, so you want to make sure you determine if it was met, partially met, not met, and why you got that, why you came to that conclusion. Revisions, we just talked about this. So if it's not working, if this plan of care is not working, we want to delete or modify. Again, we want to make sure our outcomes are realistic. We want to encourage our patients. We want to set them up for success, okay? Adjust the time criteria if needed, and then change the interventions if they're not working. So we've got new rules to redesign and improve care. These are the Institution of Medicine 10 new rules, okay? So we want to make sure that our care is based on continuous healing relationships. It's customized for our patient. The patient is a source of control. Now, when this is appropriate, absolutely. If the patient is unable to take control, then we as the nurse or we involve family, however we can, to create what we believe is the best plan of care, okay? The knowledge is shared, whether it's with oncoming staff, it should be shared with your patient. Your patient should always know their plan of care. They should always be included, okay? Evidence-based, making sure that we're doing things, choosing interventions that are backed by research. Safety is always a top priority. The need for transparency is meaning that there is no, we're not hiding anything from the patient, their family members. We're including them in every step of the way. What are their needs? What do we anticipate their needs are? Of course, we want to decrease waste. And then cooperation among clinicians, meaning that if I set up a plan of care for a patient, I want to believe in my oncoming shift should be cooperating and continuing with that plan of care. Same with an ancillary staff, whether it be physical therapy, respiratory therapy, that you're all on the same page working towards the same goal. Questions so far? So improving performance, again, if there's something not working, let's go back to the drawing board. Is there a problem? Is there a reason that we're not able to get there? Okay, let's make a change. Let's go ahead and change that. Assess how that change worked, and was it a positive thing or a negative? Do I need to make another change? QSIN, you guys will hear a little bit about this. This is quality safety education for nurses. They have this great big website, and here's where we look at data compared to other hospitals to see how people are, how we're ranking, okay? So UTIs, how are we doing with catheter-associated UTIs or falls or whatever it might be? How are we ranking, and what tools are available to help us improve those, okay? So when you're determining the adequacy of your evaluation, you want to make sure that you evaluate, did the patient achieve them? How? Let's look at the care plan. Did we revise it? Did those revisions work? Quality assurance programs, you guys don't really need to worry too much about that. But again, that's going to be looking at making sure you're following evidence-based practice steps to achieve those goals, okay? Now, this is important. We, as healthcare providers, are, again, I know I've talked about this before, we are the most trusted occupation in the world, okay? And there's a reason for that. It is so important. We are working with people's lives, that if rules are broken, things are done that aren't supposed to be done, we have to have those conversations. It's not, you know, someone got the wrong food through the fast food line. It's not, although that could really upset someone and ruin their day. This is their life, right? This is their livelihood. This is their health. We have to discuss these things, whether it's a medication error, whatever it might be. We need to make sure we communicate. They're hard conversations, but they're important, okay? So broken rules, if we see a fellow colleague doing something we know they shouldn't be doing, mistakes, if I made a med error, I've got to own up to it. Lack of support, you know, that's something that, again, we've been hearing a lot about, lack of support. How can we help that? Incompetence, maybe I'm performing a skill and I have no idea what I'm doing. I should not do that. I need to have that conversation and say, you know what, to be honest, I'm not competent in this skill. I need some help, okay? Poor teamwork, hopefully you won't see that. Nurses are really good team players. But if you're struggling and you're not able to get the help you need from your fellow colleagues, make sure you have that conversation. Disrespect is super important, whether it's between colleagues, between patient and nurse, however it might be. It's important to have that conversation. Something I've always told my students is, yes, you are here to care for that patient, but that doesn't mean that you are obligated to be subjected to their verbal abuse, if that's what's happening. So making sure that you have those crucial conversations, whether it be with your patient to tell them that's not appropriate, whether it be with management, however it might be, making sure you have those conversations that we want you to be nurses and love this field for the rest of your lives. We don't want disrespect to be a reason that you leave. Okay, micromanagement, we all know we don't love that. If you feel that's happening, go ahead and discuss that with whoever needs be. Whew. Okay, we made it. So again, you guys, this is just the foundation. As we start to layer on, when we talk about infection control, urinary, you're gonna really see where this ADPI process goes, okay? So I thank you for sitting through that. I know it was probably a little bit painful, but you guys, again, just the foundation. Remember that assessing and evaluating are somewhat of the same thing, okay? We're creating a diagnosis that we feel is best for our patient, which then will help us provide, come up with a plan, desired outcomes, and then we're gonna carry out those outcomes to the best of our ability to help our patient reach those goals, okay? That's really the foundation. What questions do you guys have? Nothing? Okay. It is 10:32. You guys come back at 10:40, and we will get into some practice questions for this chapter, and we'll dive into vital signs, okay? I will be back on at 10:40. All right, can you guys hear me? Yes, okay. All right, so what I have done is create some practice questions. So at the end of every chapter during class, we're gonna go over some practice questions together. Now, I just made a big one for all of AdPi. So we're gonna go over these together. If you guys wanna share on your chat what you think the correct answer is, or if you wanna share your screen and you can show me with those little cards, whatever you wanna do is totally fine, but I would love your participation, okay? All right, here is question 1. A nurse is gathering information about a patient's habits and lifestyle patterns. Which method of data collection will the nurse use that will best obtain this information? What do you guys think?
C.
C. Okay, so let's see what we found. Yes, C is the correct answer. Okay, it's important for the nurse to review the labs and do a physical assessment, right? But this is asking about the patient's lifestyle. So where we're going to gather that information is going to be in a history. Okay. All right, next question. A new nurse is completing an assessment on an 80-year-old patient who's alert and oriented. The patient's daughter is present in the room. Which action by the nurse will require follow-up by the charge nurse? What do you guys think? Do we like A? The nurse makes eye contact. Is this a reason that the charge nurse would need to follow up? Okay, Jeremiah likes B. So this is fine, right? Eye contact is totally appropriate. Given certain situations, we'll talk about that later, but this is okay. The nurse leans forward while talking with the patient. That's okay, right? That's body language indicating I'm listening, I'm here, okay? The nurse nods periodically. Again, that's just showing that they're listening. The nurse speaking only to the patient's daughter. We don't like that answer because the patient is alert and oriented, right? So we need to be showing respect to the patient, okay? Absolutely include the daughter when appropriate, but the patient is alert, oriented, totally capable of carrying on the interview, okay? All right. After assessing a patient, a nurse develops a standard formal nursing diagnosis. What's the rationale for the nurse's actions? So when we're coming up with a nursing diagnosis, what are we doing? So I think some people like B and some people like C. So let's talk about it, okay? We don't want to form a language that can only be encoded by nurses, right? And we don't want to help the nurse focus on their scope of medical practice because we don't do medical practice, we do nursing practice, okay? The nurse is focusing on the scope of nursing practice, okay? Medical practice is going to be a physician. To develop clinical judgment based on others' intuition, okay? So the keyword here is others' intuition. So we want to throw that one out. We're not going to develop judgment based on someone else's intuition. We are writing a nursing diagnosis to determine distinct roles that we as a nurse are going to carry out, okay? Remember that a medical diagnosis involves what the doctor decides, where they come up with the plan to treat the medical disease. We as the nurse are coming up with our nursing diagnosis to distinguish what our role is, okay? Does that one make sense? Does anyone have questions about that? Makes sense. Okay. All right. Next, Patient with a spinal cord injury is seeking to enhance urinary elimination abilities by learning self-catheterization versus assisted catheterization by home health nurses and family members. The nurse adds readiness for enhanced urinary elimination in the care plan. What type of nursing diagnosis did the nurse write? Good. So it's C, it's a health promotion. Okay, remember that. Let's go back really quick. Risk meaning that we are worried they're at risk for something. We're worried they're at risk for infection, at risk for falling. Okay, problem focused would be they have an infection, they have fallen. Okay, health promotion is when the patient is ready to take on part of their healthcare to improve their quality of life. Okay, collaborative problem isn't a type of nursing diagnosis, but again, that's when you're working with multiple entities. Okay. A patient's son decides to stay at the bedside while his father is confused. When developing the plan of care for this patient, what should the nurse do? Good. D. So we want to involve the son as much as possible. He is willing to stay there and be with his father while he's confused, which is a blessing. But also, obviously, he is invested in his father's care. So we want to go ahead and make sure that we involve him as much as possible, right? There's no need in the question. There's no indicator that there is a need for the patient to have a female. We don't want to leave the patient alone at night. He's already confused, right? It's beneficial actually to have the son there to help him. Okay. Registered nurse administers pain medication to a patient suffering from fractured ribs. Which type of nursing intervention is the nurse implementing? Is this collaborative, independent, interdependent, or dependent? So I see a couple of A's, and here's where this can be a little bit, well, the true correct answer is D, okay? But if I were giving this test, I would change, I wouldn't have collaborative and dependent as an option because they're really truly both correct. It's collaborative in the fact that the physician wrote the order and the nurse is carrying out the action, right? It's also dependent because the nurse can't do it without the physician. So again, this is a tricky one. And I would not have those both answer choices. Now I put this in here on purpose because I want you to see that sometimes we have answer choices that are very similar and can be confusing. So just know that if this were a question I were to provide for you, I would not have both options. They're both correct. Questions on that? A nurse reviewing a patient's care plan. A nurse is reviewing a patient's care plan. Which information will the nurse identify as a nursing intervention? What do you guys think? What's an actual intervention? Good. C. Now the reason that C is correct, so the patient will ambulate in the hallway twice this shift using crutches correctly. That's part of their plan, right? That's part of their planning. That's part of the P process, okay? Impaired physical mobility, that is a diagnosis, right? D, the patient is unable to bear weight. That's an evaluation. So C is the only answer that's actually an intervention. The nurse, it talks about the nurse's, it talks about the nurse's action within that. Okay, so that's the intervention. All right. The nurse is intervening for a patient that has a risk of urinary infection. Which direct care nursing intervention is most appropriate? What do you guys think? So direct care, okay? So direct care is me as the nurse physically providing care to the patient, okay? So A is the correct answer. B is indirect, C is indirect, and D is also indirect, meaning that that's not physically involving me with the patient, okay? All right. A new nurse asked the preceptor to describe the primary purpose of evaluation. Which statement made by the nursing preceptor is most accurate? Okay, so looks like we like C, which is great. C is correct. Okay, it's the most accurate. Now this is where these nursing style questions come into play. So you're gonna have to, and we'll work with you guys, but you're gonna have to learn to look at what is the very best choice, okay? And that's what makes nursing questions so difficult. Where some of these answers could be correct, you've got to identify what you know is the very most correct, which is C, right? We use the evaluation to determine the effectiveness of care. Okay, I believe this is our last one. The nurse is caring for a patient who has an order to change a dressing twice a day at 6 a.m. and 6 p.m. At 2 p.m., the nurse notices that the dressing is saturated and leaking. What is the nurse's next action? We like B. Good. We don't want to wait and change the dressing at 6 o'clock, right? Because it's already saturated and leaking. By another 4 hours from now, who knows what it would look like. We don't want to reassess it in 2 hours because we already know it's saturated and leaking. We don't need to discontinue the plan of care, right? Because we still need to perform the intervention of changing the dressing. We just need to revise the plan and do it now. Awesome. Okay, any questions so far? All right, I have one last PowerPoint, and this one's a little bit more exciting. Let me pull it up here. Okay, I apologize. It says 2019. I couldn't change it. So I made this from Powtoon. I don't know if you guys are familiar with that, but it's a really fun platform. But unfortunately, with PowerPoint, it wouldn't let me change my stuff. So vital signs. This is where we're going to get into some actual patient stuff. Okay. When you guys go to lab this week, it'll be really important that you have a foundation for this so that you can start working with each other on how to perform these skills. Okay. So vital signs. What equipment do we need to do vital signs? So in order to do vital signs, remember vital signs are going to be temperature, pulse, respiration, and blood pressure. Okay, so in order to do those, you're going to need some sort of thermometer. You're going to need a stethoscope, not only for your blood pressure, but for your respiration. Okay, you're going to need a blood pressure cuff, a watch to monitor how many breaths per minute, and sometimes a pulse oximeter, and that's going to tell you their oxygenation saturation. Okay, so this little piece right here, this is called a sphygmometer. Okay, hopefully you all have your own individual blood pressure cups. You're going to learn how to do manual blood pressure. Okay, this is a skill that is important to know, not one we use often because most places have the automated blood pressure machines, but you're going to learn how to perform a manual blood pressure. Sometimes, like in a code situation where a patient is crashing, the manual blood pressure is the only one we're able to get. So it's important that you guys learn how to use all of these, okay? So vital signs, what do they indicate? They are the indicators of physiological functioning. So they're reflecting how healthy our patient is, right? We know that with a set parameter, which we'll talk about in just a minute, if they're within those parameters, we know they're pretty healthy. If they're above or below, that makes us concerned, okay? These are life-sustaining measurements, I should say, okay? So temperature, there's lots of different ways we can take temperature. Our normal body temperature ranges from 96.7 to 100 degrees Fahrenheit. Now, in nursing, we use Celsius and not Fahrenheit. So do know 35.9 to 38 is around the same, okay? You guys will get to become more familiar with Celsius as you go on, and I have a little quick guide that I'll make sure is in your shell as well, in case you need to know the comparisons. Okay, so the most common areas to take a temperature. Temporal, that is going to cover the skin over to the temporal artery. Again, you will learn this in lab, how to perform this action, okay? It's one of the most common because it's less invasive. Tympanic is the temperature that is placed in your ear. Sublingual is the probe that goes underneath your tongue. Axillary is placed under the armpit. Now, axillary we use a lot in children. Sublingual, I don't really see so much anymore. I would say tympanic and temporal are the most common. And now they even have the ones where you just scan your forehead, okay? I didn't put this on here, but rectal temperature is also done, especially in babies. It is actually the most accurate form of temperature, okay? Pulse, this is super important, right? The pulse, it's that throbbing sensation that can be felt over a peripheral artery. So you guys can feel your pulses, whether you feel your carotids at your neck, whether you feel your radials, your brachial, your pedal pulse. You guys can assess your own pulse, but you're also going to learn how to assess others as well. Okay, but it's that you can feel it, you can palpate it, meaning you can feel and you can touch the skin and feel the pulse, okay? For an adult, regular numbers should be between 60 and 100. Now, let's say I have a patient whose pulse is 59. Although it's just barely below normal, it is below normal, so would need to be investigated. But some people who run, swimmers who are super fit have really low pulse. So it's important that you might see a low pulse and panic, but what do you need to do first? Check your patient. Look at your patient and see, are they breathing okay? Do they seem coherent? Are they alert and oriented? Are they able to perform their activities of daily living? Those really physically fit people, absolutely. So make sure that you look at your patient. Although you get a value, that's super important. That measurement is important, but what is most important is making sure that you check your patient and make sure they are okay. And ask them, wow, your pulse is really low. Is this normal for you? Yes. Okay, or no. So tachycardia is anything over 100. The word tachy means fast, okay? Tachycardia, fast heart rate. Anything over 100 beats per minute. Beats minute. Spelled that wrong. Okay, bradycardia is going to be anything lower than 60, okay? So Brady is low or slow, okay? Anything lower than 60. Respirations, that is going to be the assessment of ventilation. Okay, so ventilation is, we observe that through watching our patient, and we can also listen to their lungs as they take their breaths in and out. Often it's best if you don't tell your patient you're going to count their respirations, because for whatever reason, subconsciously, when we know someone's counting our respirations, we start to breathe differently. So carry on a normal conversation, however you want to do it, that's when you're going to count your respirations. You can listen for 15 seconds or watch for 15 seconds, multiply that by 4. You can do 30 seconds, multiply it by 2, or you can watch and listen for the whole minute. Completely your choice. Remember, normal respiration is going to be between 12 and 20 a minute, okay? Tachypnea is going to be, again, fast breathing, okay? So anything over 20 breaths per minute. Bradypnea is going to be anything less. So remember, brady is slow or low, tachy is fast or high, okay? Now, blood pressure. When we get into blood pressure, there's different stages of hypertension that are going to be important to know. The most perfect blood pressure is 120/80. Now, I have heard that soon that's going to be changed to 110/70. But for you, the purposes of you guys, your book says 120/80. So that is the guideline you want to use. That is normal blood pressure, okay? 120 systolic over 80 diastolic. The systolic blood pressure is the highest pressure, which is created during ventricular contraction, and diastolic is the lowest pressure on the arterial walls. When you guys use your stethoscope and your blood pressure cuffs, you're going to hear the sounds, the Korsakoff sounds of those beats. You're going to hear them, and that's how you're going to determine what a patient's blood pressure is, okay? Elevated is going to be between 120 to 129 systolic or greater than 80 diastolic, okay? Stage 1 hypertension, 130 to 139. Stage 2 is over 140, and hypertensive crisis is going to be over 180 systolic. Now, in a hospital setting, you might often, or a doctor's office, wherever you might be, you might see elevated blood pressures in your patient and will say, well, that's so weird because my blood pressure is normally fine. It's called white coat syndrome. And oftentimes what happens, people get nervous, anxious, stressed when they go to the doctor and their blood pressure becomes elevated. You may hear that they are then asked to take their blood pressure at home a couple times and record that and let the physician know what their true normal blood pressure is. So know that sometimes stress, anxiety, fear, those things can increase your blood pressure, okay? Hypotension, remember, hypo is below. That is blood pressure that is below 90/60, okay? Now, I can tell you that my blood pressure is oftentimes like 92/58. My blood pressure can run lower. So again, if you check a blood pressure and it's low, look at your patient. How do they look? Ask them how they feel. Because remember that we are all different. Although we know what is normal, my blood pressure just tends to run lower, and that's okay. What we really worry about is called the mean arterial pressure, and you will learn about that. There's a certain perfusion level that needs to be in order to perfuse the brain. And you guys will learn a little bit more about that later. But remember to look at your patient. So hypotension is anything that is below 90/60, okay? Do you guys have questions so far? Okay. Oxygenation is going to be measured with a pulse oximeter, and hopefully you guys have seen those. They're the little finger probes that they put on your finger. They measure how much oxygen is attached to your hemoglobin, okay? So that's what they're measuring. Normal ranges, your book is going to tell you 95 to 100% is normal. Anything below 95% is considered to be hypoxic. Now, what you have to know for any test purpose, 95 to 100% is the number. If you go in a clinical setting here in Flagstaff, you may see below 95, anywhere from 90 to 95%. Because we're at a higher elevation, those numbers are accepted and they're okay. So just know book world is always 95 to 100%, okay? But I don't want you to panic if you go to a clinical setting and see below 95%. Here in Flagstaff, that's pretty normal. So we start to worry when it drops below 90. Okay, so that's all I have on vital signs, because really what you guys are going to do is learn how to take these measurements in lab, and you're going to practice it every single lab day. So again, remember that vital signs tell you how a person's physiological state is. Are they okay? If they are below on any of the numbers, we need to assess and make sure they're okay and take appropriate measures if not, which we're going to learn about in the future. If they're above, same thing, okay? We want to make sure always, always, always look at your patient first. Okay, questions on that? For lab, you need to bring, let's see, you need to make sure, come in your scrubs, closed-toed shoes, girls have your hair pulled back. You need to bring your stethoscope, your blood pressure cuff. I believe that's it. And a pen and paper, of course. And every lab here on after, you're gonna bring that stethoscope and blood pressure cuff because you guys are gonna take your blood pressure on each other every week, okay? The thermometers and pulse oximeters are provided for you in the lab. Okay, I just have a few vital sign questions and then I will set you free. Let's see. All right. Oops. Okay. Here we are. A patient is pyrexic. Which piece of equipment will the nurse obtain to monitor this condition? Now, I didn't cover this in my PowerPoint, so if you know what pyrexic means, awesome. If not, we'll talk about it. Anybody have any thoughts? Thermometer, correct. Okay, pyrexic is a term for fever, okay? So we would need a thermometer. Perfect. The nurse is assessing the patient's respirations. Which action by the nurse is most appropriate? Good. C, right? We want to do it without the patient knowing so that they don't subconsciously change the way they're breathing. A nurse is caring for a group of patients. Which patient will the nurse see first? So this is that priority. Any thoughts on this one? Okay, I see some D's, good. So the correct answer is actually B. And the reason why is the drop in systolic blood pressure is so much, okay? It went from 128 to 100. That's a really large drop in systolic blood pressure. And when we think about it, we need to make sure that when we're looking at ABCs, right? Your blood pressure is going to help you with your circulation. So making sure that that is okay. Temperature is totally important, but we are suspecting he's hypothermic already, right? We already expected that. So that's not super shocking. The blood pressure went from 124 to 130, although that is a jump. It's not as significant as 128 to 100. And then the temperature one, we don't really need. So remember, think ABCs. What is the most significant, okay? So whenever you're looking at a priority type nursing question, you always want to think about ABCs and safety. Those are the four things you want to check before anything else. So remember, ABCs, safety. Does that help clarify the answer to that question? Okay, perfect. The nurse is assessing the patient and family for probable familial cause of the patient's hypertension. The nurse begins by analyzing the patient's personal history as well as family history and current lifestyle situation. Which findings will be considered risk factors? Now, this is a select all that apply, okay? They're not anyone's favorite, but you're going to see a lot of these in nursing. So there's multiple correct answers and we want to choose all of the correct. So let me know what you guys think. Okay, let's talk about them together. Is obesity a risk factor? Oh my gosh. Okay, obesity, yes, risk factor. They smoke cigarettes, yes, that's a risk factor. Is recent weight loss a risk factor? No. Okay, how about heavy alcohol intake? Is that a risk factor? Yes. Regular exercise, is that a risk factor? No. Okay, so we have the answers A, oh my gosh. Oh, geez. A, B, and D, right? Regular exercise and recent weight loss are actually positive things. Those are going to reduce the risk, right? Obesity, smoking, and drinking alcohol are going to increase the risk. Okay, awesome job. One more, you guys. When taking an adult blood pressure, the onset of the sound the nurse hears is 138. The muffled sound the nurse hears is at 70. The disappearance of the sound the nurse hears is at 62. Now, we didn't go over this, but in case you happen to read this in your book, otherwise we'll talk about it. Does anyone have any idea how they would rank that blood pressure? Good. The correct answer is C. Okay, so it's when you're gonna do your diastolic when you no longer hear that pulse. Okay, so it is going to be the sound that hurts. Sorry. Okay, so the systolic is going to be that first beat that they hear. Okay, and then the diastolic is the absence of. So that would be 138 over 62. Okay. Now there was a question. Let me go back. Being underweight, I don't know that there's necessarily a correlation between underweight and low blood pressure. But what I can tell you is if they're underweight, they have less to perfuse, if that makes sense. So it could be more common to see lower blood pressure in smaller individuals as they have less pressure to push against. Does that help answer your question? But it's not always a guarantee. You got it. Okay, you guys, we survived. You did so good. What questions, concerns do you guys have for me? Next week, the Dube will be open for me. So my hope is that I'll be able to actually lecture and use whiteboards where you can see me, but they're finishing the final touches on the new HyFlex down there. And I know this was a lot, but next week we're gonna go into some more exciting information, okay? Infection and safety, that's what we're gonna cover next week. You do have those pre-lecture quizzes due. I am going to set up a Zoom appointment for this Saturday. If you guys would like to do, again, no obligation to join, but you may if you have any questions for me, okay? Also, please feel free to email me. Your BB Learn Shell opens Wednesday morning. Everything for week 1 course content is what I sent you all in email, those worksheets and PowerPoints, okay? And then everything from here on out should be on your shell. I'm just trying to think of anything else I need to tell you. Does anyone have any questions for me before I set you free? Okay, the pre-lecture quizzes, perfect. So where you're gonna go, let me show you this. Hang on 1 second here. You are gonna find those on your Lippincott, okay? So let me go to mine and I'll share my screen. Oh gosh, I changed my password. Oh no, I don't know my password. Let's see. Oh no. You know how you change it and then you just save it on one device? Which is of course what I did. Now I don't know what it is. Oh my gosh. There we go. Okay. Give me 1 second. So yes, the Prep U is going to be all of the chapters. So it's a lot. I don't think that these first 5 chapters, the AdPi, should be too difficult, but yes, it is included in that. So there's quite a bit. And yes, it's okay if you don't have your name tag, as long as, since I'll be able to see your names on your Zoom, that will help. Let's see if I can fix this really quick. Okay, there we go. Let me share my screen with you guys. Okay, so here's your book. When you launch into it, you go to assignments, okay? And here it has all of your assignments in order. So you'll see that the first assignment you have is going to be those pre-lecture quizzes for chapters 24 and 27, okay? Those are due right before class. So as long as you complete them by 8 o'clock in the morning, you'll be fine. Then it has your upcoming assignments, and it has them all listed out by date, okay? If you wanted to start on your mastery of your Prep U's, you can start them. You'll see we have quite a few for this first exam. Again, 14 through 18, those chapters are, again, just that foundation that'll be built into the other chapters. So you can start those now if you would like. You can really do any of them now, I believe. That's where you find them. Does anyone have questions about that? No? Okay. All right. Any other questions? Can you take? Yes. So you'll take those Prep U until you reach that mastery. So it'll continue to give you question after question after question until you reach the mastery, a level of 3. Good questions. Yes. Clarification for the.
I had a question about one of the questions earlier. Sorry, I know we kind of went past it.
No, it's okay. Which one?
It had to do with the dependent question, or the. So does that mean that anytime like medication is involved, that it's considered collaborative, like because the nurse cannot do that like independently?
Yes.
Okay.
Collaborative / dependent. Yeah, they can't do that without an order from someone else. Great question. Any other questions, you guys? Okay, so the other thing I want to add really quickly, I have set up this a checklist for success for every week that will be in your course content. Now, there are things on there that are not worth any points and are not needed to be done, but they're just ideas to make sure that you have all of the content covered. So I will have those posted. Anything that is worth points is listed in your syllabus, okay? But you don't have to do these other things I put on there, but they're just there as an option, as an extra resource for you. So some examples would be the worksheets. There's some little videos on Course Point Plus that I put in there. Again, you don't have to do them, but I created them to just kind of help keep everybody on the right track. If you do your worksheets and you want to compare them to mine to see if they look the same or if you have the right responses, please just let me know. I'm happy to do that with you. I told you I was going to do a Zoom for Saturday for any questions, and then regular class will be, of course, starting next Monday. Hopefully I'll be in the Dube and you guys can actually see me, and that will be a little bit easier at 9 a.m. I will send you out a Zoom link for that as well. Any other questions, concerns? Anything I can do to help you guys prepare? Okay. I'll probably do the Zoom at 9 on Saturday as well, just to get it out of the way. Are the assignments the assignments are all in the Course Point Plus, which is for your textbook. The clinical skills is where you'll watch your videos, and that is just Course Point. So Course Point Plus is where you'll do your assignments. And I'll do 9 a.m. for the Zoom on Saturday. And please feel free to email me if you have any questions before then or if you're unable to attend. All right, you guys, have a really great rest of your day. Thank you for participating, and I will send an email out with this recording in case you would like to review it, okay? Thank you, have a great day.